So this is the fourth episode of the second session of Medicrew Masterclasses, and today we are going to discuss about the physiology of electroencephalogram, sleep, and then discuss the pathophysiology of different sleep disorders. As usual, we'll start with a few MCQ questions. Today's session is divided into two parts. In the first part, we discuss the physiology of EEG and sleep, and in the second part, we discuss about the somnipathies or the sleep disorders. So let us start with the first section, the physiological basis of EEG and sleep. So this is your first question. EEG recorded from the scalp represents. Next question. The slowest EEG wave is. The third question. So look at this recording which is given here. What is shown by this recording? The fourth question. What does sleep help in? So what are the physiological functions of sleep? The next question is, wakefulness, that is getting up from sleep, is stimulated by all except. So which one does not stimulate wakefulness? The sixth question is, there's a statement, stress causes reduced sleep. So this is a given statement. So what is this statement an example of? The next question is, sleep spindles and K complexes are characteristic of which stage of sleep? And the last question of this section before we start discussion is, circadian rhythm is regulated by which part of the brain? So with this, let us go and discuss these physiological aspects of EEG and sleep, and we'll come back to these questions before we start with the next section, which is on sleep disorders. So what is EEG? Electroencephalogram, as the name suggests, is recording of electrical activity of the brain from the surface. So by surface we mean from the scalp. So it is a non-invasive procedure usually, unless you want to find out the deep EEG findings. So the routine EEG is electrical recording of the brain from the surface of the brain, that is basically the scalp. Now, we used to think that EEG represents action potentials of neurons. But if you see the way the neurons are arranged in the cerebral cortex, the upper part is a dense forest of the dendritic tree. So when you place the electrode on the scalp surface, you will rarely record the action potentials, which can be recorded only deep down the brain. So practically, the EEG that we record are summation of the dendritic postsynaptic potentials as shown in this diagram. You can see that the action potential can only be recorded from very deep down. So it becomes an invasive procedure then. When you record from the surface, the routine EEG essentially measures the dendritic postsynaptic potentials in a summated form. And this manifests in the form of different waves, and the waves are characterized by different intensities, frequencies, and patterns by which interpretation is done. The discovery of EEG is something very interesting, which I must share this story with you. EEG is a typical example of where discovery started with the paranormal and supernatural and ended up in being science. So Hans Berger was a psychologist and physiologist who was studying the brain functions. But this study came after a quote unquote supernatural event. Hans was once riding a horse and he fell down from the horse. And see, looking at the birth date and the lifespan of the person, you can understand during that time telecommunication, even postal services were not very frequent. So when he fell down from the horse, a few days later, he received a letter from his father saying that his sister was having a premonition, an intuition that he has fallen down and injured himself. This was something very unusual because no one should be able to understand that so fast in those days. And therefore, he started thinking that there are telepathic communications between human beings. So he started setting up a number of psychic experiments, not psychological. So these are paranormal experiments where people will be placed at distances in different rooms. They will be thinking about common objects and he would be comparing the EEG picture, the images of different individuals. Obviously, the experiment was a great failure. There was no correlation made whatsoever. But as a byproduct of this supernatural experiment, at least he learned that the activities of the brain can be recorded. And then he changed the perspective and started studying the functions of the brain with the same waves. And this is how the first EEG was recorded. In this connection, I think it's also very important for us as students of science to understand that people who practice science or teach science do not always necessarily have a scientific aptitude. Knowledge and practice are two essentially different things. So there are scientists like Isaac Newton who used to believe in alchemy. There are prominent scientists and medicine specialists who can promote quackery. So just because someone from the stream of science proposes something, it does not become a science. And we must be useful, it must be useful to use a filter of what to take from them and what not to take from them. Because they are also human beings with their own prejudices and biases. So we took the EEG technology from Hans Berger, but not the psychic theory from Hans Berger. This is how the modern EEG came through supernatural and parapsychological experiments. Now, the procedure of EEG is usually non-invasive. So we put the electrodes on the brain in a particular pattern. These patterns are known as montage, and different montages are used for tracing the activity of different parts of the brain. Superficially, these waves can be recorded, and we usually find four basic patterns of waves. Although understand that the characteristic of the normal and abnormal EEG wave are huge, and that is totally beyond the scope of today's class. So we are only discussing the most common types of waves that we see in the normal EEG. So in the normal EEG, we find the different waves, and the waves are characterized by their frequency. That is, how many waves are there in 1 second. So that is one important criteria for classifying. You can see high frequency waves are clustered together. Low frequency waves are widely separate from each other. Now in the sequence of high frequency to low frequency, the highest frequency is seen in the beta waves. The beta waves have the highest frequency of 13 hertz, that is at least 13 to 20 per minute, per second, I'm sorry. Next comes the alpha waves, 8 to 13 hertz, that is 8 to 13 wave per second. Then comes the theta waves, that is 3.5 to 7.5 hertz. And finally comes the delta waves, which are the slowest and also one of the tallest waves. And these are 3 hertz or less. So per second contains about 1 to 3, even less than 3 waves. So the frequency progressively decreases along beta, alpha, theta, delta. Beta being the fastest and delta being the slowest in the normal EEG. When we are awake, when we are highly awake with the eyes open, we are listening to things, we are thinking about things, then the activity of the brain is a high frequency activity. So we get beta waves. Now, there is a very interesting phenomenon that can be demonstrated, which is called alpha blocking or desynchronization. If a person closes the eye and sleeps restfully without doing any mental activity, the waves become slower and it transforms into the alpha wave that you see in the first part of this. So if you look at the first part of this diagram, the first part is alpha wave. Once the person either opens the eye or pays mental attention to something, for example, once the person pays attention to a mental mathematics or starts doing some deep thinking in the mind, even without opening the eyes, the frequency increases. The wave becomes smaller, but the frequency increases and it changes to beta wave. If the person again closes the eye and stops thinking, then again the alpha pattern will come back. This disappearance of the alpha pattern when the eyes are open or the person is mentally active is known as alpha block. And because it is associated with increased alertness, it is also known as arousal phenomenon or alerting response. In old days, this was called desynchronization because suddenly a synchronized rhythm changes into fast rhythm. But this word desynchronization is a misnomer. All EEG activities are synchronized activity. So maybe the pattern has changed, but it has changed to a more rapid synchronization. So we should not actually call it desynchronization, which is a misnomer. So what does alpha block tell us? Alpha block tells us that the activity of the brain increases when we start thinking or when we look around with attention. And that is why the frequency of discharge from the dendrites also increase, converting the alpha rhythm into the beta rhythm. While answering your question, Satyam, you have asked a very important question. There are experiments and also anecdotal evidences suggesting that hearing certain kinds of wave frequency increases focus in studies. And that has been sometimes proposed as various non-conventional therapies. Honestly, there is no such proof. There is no such proof that hearing a particular frequency of sound will effectively increase the attention. While it is true that hearing a monotonous background noise often cancels out the background echo and therefore increases concentration. This is something that happens when you listen to music and work. But whether a particular frequency can cause the so-called brainstem activation or arousal response is totally not proven by science. So I think we should take it with a pinch of salt. The arousal mechanism, that is this wakefulness and sleep cycle, is largely regulated by a part of the brain called the reticular activating system. In the midbrain and the pons, there is a network of neurons. These neurons arises the whole brain to active focused attention. So the way we become conscious of ourselves, the way we become alert and oriented to the surrounding is because of the reticular activating system. It's a system of arousal that is present in the body. The reticular activating system has both excitatory and inhibitory areas. Obviously, the excitatory area will make us more alert. The inhibitory area creates a balance so that sometime we can tune down the alertness and sleep. The excitatory area is present in the upper part of the brainstem, that is upper mid-pons and midbrain, whereas the inhibitory area is present in the lower part of the brainstem, that is the lower mid-pons and the medulla. So if you look into this diagram, the upper part, you can see it's labeled also, is the excitatory area, and the lower part is the inhibitory area. And the inhibitory area inhibits the excitatory area, creating a balance between the two. The excitatory area receives signal from the periphery, also the face and the cortex. So when you think, the cortex stimulates the excitatory area. When you see something, your cortex excites the excitatory area. When you get peripheral signals in the form of pain, in the form of sound, in the form of smell, that will all stimulate the excitatory area. And its overall functions, therefore, will be wakefulness, to maintain the tone of anti-gravity muscle so that we can stand and just not fall down. And it also controls the level of activity of spinal cord reflexes. That is why reflexes become prominent when we are awake and they get diminished when we are asleep. The reticular activating systems uses acetylcholine as a neurotransmitter. The inhibitory reticular area includes the raphe nucleus, and it is present in the lower half of the pons and medulla, as we said. And they function as inhibitory centers that inhibit the activating center, and they use serotonin as a neurotransmitter. Now, if you again look at the reticular activating system, you see that the reticular activating system projects the neurons upward as well as downward, which means it controls the spinal activity by the descending reticular system and controls and communicates with the hypothalamic centers and the cortex by the ascending system. So it's a two-way system where it is communicating with higher centers and also controlling the lower centers of the central nervous system. Sleep is a state of unconsciousness, and we all sleep. And sleep is a state of unconsciousness from which we can be easily aroused. And when we cannot be aroused, that unconsciousness is called coma. From a very numerical point of view, if we categorize coma in the Glasgow Coma Scale, a score of less than 8, that is 7 and downwards, is usually considered to be unarousable state. Sleep never goes below 8 in the Glasgow Coma Scale. From the biological point of view, sleep is divided into slow wave sleep and rapid eye movement sleep. The slow wave sleep is characterized by slow EEG waves and there is no eye movement. Whereas in the rapid eye movement or REM sleep, the waves of the EEG are very fast and there is movement of the eye, as evident if you look at the eye or even if you do a study of the nystagmography by looking at the oscillation of the eye during sleep. So what are the differences between the slow wave sleep and the fast wave or REM sleep? The slow wave sleep is the major part of the sleep. About 75% of the sleep is slow wave. It is a peaceful and restful sleep, and it decreases all vegetative functions of the body. So the vessel tone decreases, blood pressure decreases, pulse decreases, respiratory rate decreases. the basal metabolic rate decreases. And so the classical sleep is basically the slow wave sleep, when all physiological activities are gradually shutting down. Dreams can occur in the slow wave sleep, but they are not remembered. We cannot remember what dream we had during this slow wave sleep. A more superficial sleep is the REM sleep. During the REM sleep, as the name suggests, there is rapid movement of the eyes. And there are episodes of REM sleep of 5 to 30 minutes every 90 minutes of the sleep cycle. Patient can have vivid dreaming, and the dreaming can be remembered during the REM sleep. Most of the time when we wake up after seeing a dream, that is during the REM sleep that we wake up. The patients are difficult to arouse during the REM sleep, and the muscle tone is depressed, although there may be irregular muscle movements. The brain metabolism is increased. Because the brain metabolism increases, because eyes move, because some muscles can also move, it looks like that the patient is awake. Sometimes, therefore, it is known as paradoxical sleep. But it is actually sleep because the patient is difficult to be aroused and the patient is actively dreaming. So there are different theories of sleep. Without going into details of that, the theories are broadly divided into two categories: the passive theories of sleep and the active inhibitory process theory of the sleep. We have seen that in the reticular activating system, there is an excitatory area, there is an inhibitory area. So the passive theory says that the excitatory areas become tired and fatigued, and therefore the person falls asleep. Whereas the inhibitory process theory says that the inhibitory area will actively inhibit the excitatory area, and this is what causes sleep. Probably both are true to some extent. There are different physiological functions that sleep can perform, like remodeling of the synaptic function, restoring the natural balance among the neuronal center by helping them store neurotransmitters. It restores balance in the other functional system, giving rest to various parts of the body, reducing fatigue of the muscles, reducing fatigue of the neuromuscular junction, etc. And also, sleep has been shown to consolidate learning. So, a part of the long term potentiation definitely happens during the sleep. The cycle of falling asleep and again waking up from the sleep is a very complex process. We usually sleep for 7 hours a day. That's like 6 to 8 hours of sleep a day. And the remaining 16 to 18 hours, we usually remain awake. Although this can vary from one person to another person. The nuclei in the brainstem and the hypothalamus are very critical for the transition between sleep and wakefulness. It is seen that if you stimulate the posterior hypothalamus, it causes arousal. If you stimulate the anterior hypothalamus, the person goes to sleep, which indirectly says that there are certain centers dedicated to arousal mechanism and the sleep mechanism. So what exactly controls the sleep cycle? What decides when we should fall asleep and when we are not going to fall asleep? The regulation of the sleep and the wakefulness cycle is done by at least three mechanisms: the homeostatic mechanism, the allostatic mechanism, and the circadian rhythm. It's very important that we understand the differences between these three mechanisms. Homeostatic mechanisms refer to all mechanisms that resist a change in biological set point. That means, suppose my body temperature is 37 degrees Celsius. Even when I'm exposed to a cold environment, my body will try to maintain it at 37 degrees by producing more heat, by shivering, by lipolysis, etc. This is homeostasis because the aim of the system is to prevent a change in the set point. Suppose my plasma osmolarity is 300 milliosmol per liter. So when my plasma is becoming concentrated, my thirst center is stimulated and I drink water. The plasma again gets diluted to 300 milliosmol per liter. This is a homeostatic mechanism because it is preventing a change in the biological set point. Then comes the allostatic mechanisms. So what is an allostatic mechanism? Allostatic mechanisms are adaptive mechanisms that help the organism survive by changing the set point. So in allostatic mechanism, the set point is changed. So what are examples of this? So for example, you have an examination coming up. Normally you sleep 7 hours a day. But due to the stress of the examination, you are waking up 12 hours per night. Of course, it is not a homeostatic mechanism because your body is creating a change, but it is helping you survive the additional stress. And therefore, you feel apparently relaxed that you have got enough time to study. Suppose a person is bereaving, a person has a tragedy happening in the family. So the person cannot concentrate in work properly. So now the person develops a habit of smoking or drinking, which helps the person cope up, albeit not in a very physiological manner. It will cause damage to the body, it will damage the liver, the lungs, etc. But it will also help the person cope up with the grief. So this is an example of allostatic mechanism. So in general, allostatic mechanisms can be harmful to the body, but they have some temporary benefits given to the patient. Finally comes the circadian rhythm. Circadian rhythm refers to the day-night cycles that are entrainable, which is very important. That is, circadian rhythm is a typical day-night cycle that happens. There is a particular time when you get up from the sleep. There is a particular time when you start feeling hungry. There is a particular time you feel your bowel motion will start. There is a particular time when the cortisol level rises. There is a particular time when you start feeling sleepy. These are all parts of the circadian rhythm, but they are entrainable. So if you adapt to a different lifestyle, initially you will have some problem. But with 7 days or 10 days or 21 days of practice, gradually these problems will be overcome and your body will learn the new kind of setup. This is something that you even see in your real life. During the examination, if you wake up at 5 a.m. every day, which you don't do maybe regularly, even when there is no examination, after the last day of the examination, you suddenly wake up at 5 a.m. because the body has now newly learned to wake up at 5 a.m. That is why we say that the circadian rhythm is an entrainable phenomenon. You can train the body to follow a particular rhythm. These three kinds of mechanisms, the homeostatic mechanisms that resist a change in the biological set point, allostatic mechanism that help the organism survive by changing the set point, and circadian rhythm, which are entrainable day-night cycle, together determine the sleep-wakefulness cycle. So up to this, is this clear? Did you understand the three types of mechanism? Then I will come into details of how it performs. Okay. So let us now see what are the homeostatic, allostatic, and circadian mechanisms of sleep. The homeostatic mechanism is also known as neurochemical mechanism of sleep. So it talks about the systems of neurotransmitters in different parts of the brain that either induce sleep or induce wakefulness. In the brainstem, there are certain nuclei that are part of the reticular activating system. We have seen that. In the pons, midbrain, and medulla, there are brainstem nuclei that are part of the reticular activating system. In these nuclei, if noradrenaline and serotonin increase, it causes a decrease in the acetylcholine in the subsequent synapses. And reduced acetylcholine causes wakefulness. So in these nuclei, if noradrenaline and serotonin increase, then acetylcholine decreases, and this causes waking up. From this, we can easily remember that anticholinergic drugs like benzhexol or benztropine usually cause reduced sleep. If noradrenaline and serotonin decreases, obviously then acetylcholine increases, and this induces the rapid eye movement sleep. So increase in acetylcholine can cause rapid eye movement sleep. On the other hand, the non-REM sleep is usually balanced by the hypothalamic centers. So hypothalamus also has circadian and homeostatic centers. In the hypothalamus is if GABA increases, gamma aminobutyric acid, the inhibitory neurotransmitter, if it increases, it causes a decrease in histamine. And decreased histamine causes reduced activation of the thalamus and cortex, leading to non-REM sleep. The opposite is also true. So when there is reduced GABA, there is increased histamine, there is increased activation of the thalamus and cortex, which causes wakefulness. It's very interesting to see here how different drugs utilize these mechanisms. For example, any drug that increases the activity of GABA will cause non-REM sleep. So the GABAergic drugs like the benzodiazepines, the Z drugs or the barbiturates, they all cause increased sleepiness. Similarly, antihistaminic drugs will prevent sleep. Will induce sleep because histamine causes wakefulness. So antihistaminics like promethazine are sedative because they inhibit the stimulatory action of histamine. The classical anticholinergic drugs, the central anticholinergic drugs, cause reduced sleep. For example, benzhexol can cause reduced sleep. There are certain drugs which have antihistaminic side effect, and therefore they are used to induce sleep. So this is an example where side effects are used as pharmacological effects. And we will discuss about those drugs later in the part of today's class. So this is the neurochemical mechanism of sleep. So wakefulness is promoted by noradrenaline, serotonin and histamine. And wakefulness is inhibited by acetylcholine. Similarly, acetylcholine promotes the REM sleep, whereas GABA promotes the non-REM sleep. So this is the homeostatic regulation of sleep. So this is exactly what will happen when the patient will have a normal sleep cycle. There are certain drugs which are anticholinergic and antihistaminic drugs. The final effect will depend on the balance between the anticholinergic and antihistaminic action. Usually drugs which are antihistaminic plus anticholinergic have far greater antihistaminic action than anticholinergic action, and therefore they end up being sedative drugs. A similar example is also the tricyclic antidepressants, which increase noradrenaline and serotonin. So they should ideally cause wakefulness, but they have antihistaminic side effect, which is much stronger in the low dose. And therefore, tricyclics can actually cause sleepiness instead of causing wakefulness. Now coming to the allostatic mechanisms. The allostatic mechanism is a response to a stress. It's a physiological response to a challenge like a physical danger or psychological threat that cannot be managed by maintaining the set point. These stress responses can impact the need for and the ability to sleep. For example, insomnia is common in patients with anxiety and other psychiatric disorders. Maybe waking up reduces their anxiety, but it also reduces their sleep. So this kind of reduction is not a homeostatic mechanism. It is an allostatic mechanism. Finally, we come to regulation of the circadian rhythm or the day-to-day rhythm of different activities. So circadian rhythm is the regular recurrence of physiological processes which occur in 24 hours. And it is a very entrainable thing. The circadian rhythm is largely regulated by daylight and darkness cycle. And this is regulated by a hypothetical part of the brain called the biological clock. Recent studies suggest that probably the suprachiasmatic nucleus of hypothalamus is the functioning biological clock. So how does the suprachiasmatic nucleus regulate the day-night cycle? It's a common observation that when you sit in a dark room, you feel asleep. And also when you are in a bright light, the sleepiness decreases. This is one reason why lecture theatres should not be dark in order to highlight the projector, because it actually makes people fall asleep. So why is it that dark rooms make us asleep? What is the mechanism behind that? The mechanism can be traced with the help of this simple diagram. When light falls on the eye, the light travels from the eye to the hypothalamus. And this happens through a neuronal tract known as the retinohypothalamic tract. So when light falls on the eye, not only is the visual pathway stimulated, another pathway is stimulated from the eye to the hypothalamus, and this is called the retinohypothalamic tract. The retinohypothalamic tract carries the impulse of light to the suprachiasmatic nucleus, from where it goes to the paraventricular nucleus. However, paraventricular nucleus is not the main regulatory center. The main regulatory center is the suprachiasmatic nucleus. From there, it goes to the hindbrain, the spinal cord, and the superior cervical ganglion. Whatever it does, ultimately it releases noradrenaline. And this noradrenaline acts on the cells of the pineal gland. So this is the pineal gland, and you can see therefore the cells are known as pinealocyte or pineal gland cell. So from the cervical ganglion, noradrenaline is secreted and it acts on the pineal gland cells. We know that noradrenaline will act on beta adrenergic receptor, and ultimately the beta adrenergic receptor stimulates an enzyme. This enzyme activates the formation of the hormone melatonin. So in the pineal gland cells, the tryptophan is converted to 5-hydroxytryptophan, then to 5-hydroxytryptamine or serotonin. The serotonin is converted to N-acetyl serotonin by the enzyme N-acetyl transferase. And finally, that is converted into melatonin. This N-acetyl transferase enzyme is induced by cyclic AMP. And this induction happens by beta-adrenergic receptor, which is stimulated by noradrenaline. The noradrenaline is stimulated when the suprachiasmatic nucleus is activated. So this whole pathway remains active in darkness, and when light falls, this pathway is inhibited. So the pathway is actually like this. So when there is darkness, the whole pathway remains activated. So if there is no light, there is no inhibition of the suprachiasmatic nucleus. And therefore, the melatonin secretion occurs, causing sleepiness. When there is light, the light causes inhibition of the suprachiasmatic nucleus. And therefore, this pathway is blocked, melatonin secretion decreases, and the patient becomes less sleepy or awakeful. It is very difficult to say how blind people gradually get accustomed with circadian rhythm. The probable mechanisms can be that there is some kind of a cortical plasticity, so that instead of visual cues, they start taking auditory cue or olfactory cue for the circadian rhythm. That is one possibility. The situation will also be different if a person was not blind from birth, but had the activation of this system. Thirdly, Similarly, it is also very doubtful as to how uh, congenitally blind people would dream. Now, what is very interesting is it is also seen that from third trimester onwards, the fetus can have dream-like visions, as evident from the electroencephalography of the fetus. What they see or feel, we do not know. They have not seen anything of this world. What is probable is that during sleep, we actually do not see things. During sleep, the brainstem nuclei, the amygdala, are highly stimulated, indicating that the emotion related to the activity is activated rather than the activity. So, for example, when you are chased by a tiger, you have a particular kind of emotion. Sleep probably replicates the emotion, not the activity. But because the human brain has a capacity of projection, we project the emotion to find the nearest memory that we have related to that emotion. And we start thinking that probably that is the event that we are seeing. So that is one important theory of sleep. And this explains why even blind people can dream or the blind people can develop circadian rhythms. SCG stands for the superior cervical ganglion. So we understood that sleep is very complexly regulated by homeostatic neurochemical mechanisms, by allostatic mechanisms of lifestyle adjustment, and by circadian rhythm, which operates via the suprachiasmatic nucleus, by the release of melatonin. Sleep has been divided into a few stages on the basis of EEG finding. During the awake state, we have seen the brain waves are very fast and they are known as beta waves. As the person becomes drowsy, they are replaced by the alpha waves. Now the person enters the stage 1 sleep. The stage 1 sleep is characterized by even slower waves known as the theta waves. As the person goes to stage 2 sleep, the waves will become even slower. Occasionally, there will be clusters of or bursts of activity known as sleep spindle, or large complexes known as K complexes. However, what is the exact significance of the sleep spindle and K complex is not quite understood. What is important is that they should be distinguished from epilepsy. We must understand that these are normal waves and should not be confused with an epileptic focus. In the stage 3 and 4, the sleep becomes a very slow wave sleep. So it is also called slow wave sleep when the delta waves will dominate. In between, every 90 minutes, we will have bouts of REM sleep that will look like wakefulness. The muscles will be paralyzed, but there will be some automatic movement of the muscles. And the person will be having vivid dreams and eye movement. Now, this cycle does not happen in sequence like this. So if you look at, say, for example, the first graph, this is known as a hypnogram or the sleep diagram. You see on the y-axis, we have plotted the stages of the sleep. The most superficial is the REM sleep. And then we have the non-REM 1, 2, 3, 4 stages. The person will go from the awakeful state down to stage 4, and then again from 4, 3, 2, 1, the person will go back to the REM sleep. And again the person goes down and again goes up. And you can see the movement is not symmetrical. You may not always reach to the top, you may not always reach to the bottom. And this is how a typical sleep cycle occurs. As the sleep progresses, you can see the depth of the sleep gradually becomes less and less, and finally we wake up with a dream, that is the REM sleep. So this kind of a diagram is known as a hypnogram, and hypnogram varies a lot between different age groups, different ethnicities, and with people with psychiatric comorbidities. So this is the normal sleep cycle, and let us now try to solve the questions that we started with. The first question is, EEG recorded from the scalp represents. Wonderful. The answer is summation of dendritic postsynaptic potentials. Next question. the slowest EEG wave is? Very good. The answer is delta wave. Next question. What does this recording show? Yes, the recording shows the phenomenon of alpha block. Next question. What does sleep help in? The sleep helps in all of the above. Next, wakefulness is stimulated by all except. So which one does not stimulate wakefulness? Wonderful. Acetylcholine makes us fall asleep, and so increased acetylcholine is the answer. Stress causes reduced sleep. What kind of mechanism is this? Wonderful. This is an example of allostatic mechanism. Sleep spindles and K complexes are seen in. Yes, they're seen in the non-REM sleep stage 2. And the last question, circadian rhythm is regulated by. Yes, the answer will be suprachiasmatic nucleus. Although paraventricular nucleus is part of the loop, but it is neither directly activated or inhibited. So the switch lies with the suprachiasmatic nucleus, and therefore that is the biological clock of the body. We now start with the second part of today's discussion, that is the common sleep disorders. So I should confess at the beginning that sleep disorder is a huge subject in itself, and it's not possible to cover that in a few minutes. So I will give an overview of the sleep disorders and only discuss some common and interesting sleep disorders as examples. Let us try with this question. The sedative drug having minimum effect on the sleep stages, muscle tone, or seizure. Next question. Insomnia secondary to depression is best treated with. Next question. Modafinil can be used to treat. Next question. AHI, that is apnea hypopnea index. That's a kind of a breathing index. between 15 to 30 indicates. Next question. All of the following are non-REM sleep disorders except. So which one is an REM sleep disorder? That is the question. Next question. Sleep paralysis occurs during. So during which stage do we have sleep paralysis? Next question, and this is the last question of the section. Which one is a true statement? Sleep terrors are vividly remembered. Nightmares are usually forgotten. Obstructive sleep apnea can lead to cardiac disease. And Rameltian is a melatonin receptor antagonist. Okay, so with this, we finish the initial question answer round, and we will now discuss these questions and get back to the questions again. So when we use the word sleep disorder, what do we exactly mean? We know that adults need about 6 to 8 hours of sleep per night. That's approximately 7 hours of sleep per night to promote their optimum health, although the timing, duration, and the internal structure of the sleep can vary. Sleep disorders are considered in those patients who report that the sleep related problems are happening at least 3 times per week for a period of 4 weeks. So in 1 week, there should be at least 3 disturbances, and they should be happening at least for 1 month. And who perceive their sleep problems as impairing, that is, during the day they cannot work or they are physically becoming weak. Only then it is known as a sleep disorder. An occasional nightmare, one solitary episode of sleep paralysis does not warrant a diagnosis or a treatment. Patients may seek help from a physician because of three chief complaints. Either they will be feeling excessive daytime sleepiness, or they have difficulty in initiating or maintaining a sleep, which is called insomnia, or there may be unusual behaviors during sleep, which is called parasomnia. So the fundamental three chief complaints in a sleep clinic are usually excessive daytime sleepiness, or reduced initiation or maintenance of sleep, or unusual behavior during the sleep. The last one has been culturally likened to paranormal activities. There is an international classification of sleep disorder which is huge. The primary 7 headings of that include insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep-wake disorder, parasomnia, sleep-related movement disorder, and other sleep disorder. But as I told you that it is totally beyond the scope of today's session to cover all of them. So I will be selecting some common sleep disorders that we encounter in clinical practice or in our day-to-day life and discuss their pathophysiology and management. Insomnia is a fairly common phenomenon. There are many people who will say, I can either not fall asleep easily or during the sleep, I wake up again and again repeatedly. Insomnia is sometimes divided into chronic or short-term or other disorders. Chronic insomnia is often due to a medical condition like asthma or cardiac failure or some long-term stress. Short-term insomnia can be situational. That may be due to anxiety of an examination. That can be due to loss of a beloved one. And other forms of insomnia can be drug induced or secondary to other neuropsychiatric disorders. When a person suffers insomnia, we have to advocate behavioral therapy, which is known as sleep hygiene. That is maintaining a proper sleep schedule, avoiding smoking, alcohol, and caffeine before the sleep, going to bed at a fixed time of the day, not using electronic devices before the sleep, not changing the layout of the sleeping room quite often, and not using the bed in the daytime. Apart from this, drugs that help in inducing sleep or maintaining sleep includes benzodiazepines like lorazepam, clonazepam, and alprazolam, the Z drugs like zolpidem or S-zopiclone or zaleplon, antidepressants like doxepin or mirtazapine, and melatonin antagonist, which can be melatonin itself or rameltian. Now, what is interesting is how to know which drug to be used when. Unfortunately, the mechanism of the drug do not always relate with the use. So we depend on an evidence-based approach. Whatever has been statistically found to be useful is used. Benzodiazepines are very good sleep-inducing agents, but they cause a lot of hangover and drug dependence. However, one good point is they have very good muscle relaxant activity and they also have anti-seizure activity. Z drugs do not alter muscle tone, do not have any effect prominently on the sleep cycle structure, or they also do not have any anti-seizure activity. But the good part about the Z drug is, although they stimulate the benzodiazepine 1 receptor, they do not cause dependence. So drug dependence is not a major problem with the Z group of drugs. Antidepressants, which include doxepin and mirtazapine, are sedative antidepressants. So they are preferred to be used in patients who have depression as well as insomnia. Remember, all serotonin reuptake inhibitors reduce sleep because serotonin reduces sleep. So as a result, SSRI should be avoided if a depressed person also has insomnia. Ideal drug for such people will be a drug having antihistaminic effect. Doxepin and mirtazapine are noradrenergic and serotonergic drug. However, their antihistaminic side effect is much more pronounced in low dose over their own effect. So apart from mildly curing the depression, they can also help in inducing sleep by their antihistaminic action, not by serotonergic or noradrenergic action. That is why doxepin or mirtazapine, because of prominent antihistaminic side effect, are used therapeutically in sleep disorders with depression. Melatonin agonists are particularly useful in circadian rhythm disorders like jet lag. They can also be used in patients who have a chronic sleep disorder. So the American Association of Family Physicians proposes an algorithm like this. If you diagnose a patient with insomnia, you first do behavioral intervention, induce sleep hygiene. Many people will resolve with that. So if the symptoms are resolved with this, no further treatment is needed. But if the symptoms still remain, you determine the type of insomnia. Is it a sleep onset insomnia? Is it a sleep maintenance insomnia? Is it insomnia in old people or is it depression associated with insomnia? If it is a sleep onset insomnia, you can induce the sleep with melatonin, Z drugs. If it is sleep maintenance insomnia, Z drugs or doxepin are evidence-based drugs of choice. When insomnia occurs in older adults, you can use the melatonin agonist as well as doxepin. Whereas when depression and insomnia coexist, we use antidepressants with antihistaminic action, that is doxepin and mirtazapine. So this is the proposed guideline for treating different kinds of insomnia in common practice. Is it clear up to this? Then we come to something that is opposite of insomnia, that is narcolepsy. Narcolepsy is a chronic sleep disorder. where the person suddenly has attacks of sleep and falls asleep. It is characterized by cataplexy, which means sudden loss of muscle tone. Sleep paralysis, the person cannot move the body during sleep. Hypnagogic hallucination, a vivid dream that looks like hallucination, usually full of terror. And automatic behaviors, which can be as simple as throwing the hands or legs or as complex as sleepwalking. The exact mechanism of narcolepsy is not very clear, and it can be diagnosed by study of the EEG and ECG during sleep, something that we call polysomnography. A polysomnography tracing typically looks like this. It has multiple parameters on the y-axis, and then a sleep specialist will analyze the graph and come to a diagnosis. The treatment includes using stimulant drugs, which are derivatives of amphetamine. So we can use methylphenidate, modafinil, which are amphetamine derivatives, or protriptyline that increases serotonin and noradrenaline and therefore helps the person remain alert. A sleep-related breathing discomfort is obstructive sleep apnea. Normally, when we sleep, our airway should remain patent as shown in the diagram above. But if a person has obstructive sleep apnea, the tongue or the palate can become patulous and loose, and therefore the airway closes. So the person will wake up again and again with severe breathing discomfort and snoring. This is known as obstructive sleep apnea. It can be caused by obesity, it can be caused by neuromuscular problems, it can be caused by an adenoid, it can be caused by a large tonsil, and many other factors. When obstructive sleep apnea occurs, the person during sleep has intermittent hypoxia. Oxygen level falls in the body. We know that when oxygen level falls, sympathetic activity increases. Hypoxia also stimulates oxidative stress because we know that during hypoxia, certain enzymes are induced. So next time when the oxygen goes in, there is a burst of free radical formation. The same thing can also cause inflammation. Ultimately, it causes endothelial injury, leading to hypertension, atherosclerosis, arrhythmia, and heart failure. So, obstructive sleep apnea most often complicates into cardiac problem. And it is also seen that people who are more obese, particularly having a body mass index more than 30, have greater chances of obstructive sleep apnea. Whether it is the obesity that causes the apnea or the apnea that causes the obesity remains unclear. It can be actually a both-way pathway. But what is true is weight loss reduces the sleep apnea. So one of the major techniques to reduce sleep apnea is to ask the patient to lose weight. If the person is not satisfactorily relieved, we can use positive pressure ventilation devices like the CPAP. So there is a indexing score known as the apnea hyperpnea index score, also known as the AHI score. It is basically the number of breathless episode you have per hour, and it can be measured by sleep studies. So if the number of episode is less than 5, it is normal. Normal people can have such choking episodes during sleep. If it is between 5 to 15, it's called mild. 15 to 30, it's called moderate. And more than 30, it is known as severe. So whenever a person has a scoring done, the treatment can be aligned with the scoring. Mild sleep apnea can be treated with weight loss, oral appliances to keep the mouth open, or with continuous positive airway pressure or CPAP. Severity, when it increases to the moderate level, we need oral appliance and CPAP almost always, and weight loss may not be totally helpful. And when it is very severe, even surgeries may be needed to restructure the oropharynx or the nasopharynx, and CPAP becomes mandatory. So this is a very short summary of obstructive sleep apnea. Now we come to the more interesting domain of sleep disorder known as the parasomnias. The parasomnias are abnormal behaviors that are associated with sleep cycle. They are usually classified by which stage of the sleep is affected by this. So they are called non-REM parasomnia, REM parasomnia, and other parasomnias. Non-REM disorders can cause confusional arousal. You wake up and don't understand anything. Sleepwalking or somnambulism, sleep terror, and sleep-related eating disorder. Whereas the REM parasomnia can include different kinds of behavioral disorder, sleep paralysis, and nightmares. So let us discuss a few of them which are very interesting and common. Sleep terrors or night terrors are more commonly seen in children, but it can happen at any age. This is characterized by screaming, intense fear, and flailing while still asleep. But the person actually wakes up, and this is known as night terror. When the person wakes up, the person does not remember anything. That is very peculiar. So most night terrors last about 10 minutes. They can also continue for 30 to 40 minutes in some children. After the episode, the children fall back into a deep sleep and typically have no memory of the night terror the next morning. This is something that distinguishes night terror from nightmare, because nightmare is remembered. So nightmares are unpleasant or frightening dreams that cause emotional distress. Unlike night terrors, nightmares usually occur during REM sleep and don't involve physical or vocal behavior like talking. It is common to remember the details or the feelings of the nightmare, and some may even become recurring dreams. Regarding this remembering the nightmare, there is a common analogy. Suppose when you are jogging for morning walk, you don't really remember how many steps you jogged, but you definitely remember that you jogged. Similarly, when a nightmare happens, you may not remember the individual second by second details of the nightmare, but you can definitely summarize and remember overall what happened during the nightmare. That is the kind of recollection that we have during nightmares. Sleepwalking is another important type of disorder that is associated with the non-REM sleep disorders. It involves getting up and walking around in a state of sleep. It's more common in children than adults and usually stops by the teenage. But in some cases, they may not stop by teenage, and then that requires treatment. They will usually not require any treatment unless it includes serious behavioral problem, like going out of the house, like handling sharp equipments, or going out in the terrace from where the person can fall. Sleep-related eating disorder often accompanies patients with sleepwalking. So in the sleep, they can walk up to the refrigerator or to the kitchen, they can eat, they can wipe off their face and then forget that they have eaten. So this is another very interesting disorder that can happen in the non-REM sleep disorders. Sleep paralysis is a very frightful disorder. It's a state of being unable to move or speak. It typically happens when we are transitioning between REM sleep and awakefulness. Most commonly, it happens during waking up. So when we are trying to wake up, sometimes the brain wakes up, but the body does not wake up. What I'm trying to say is that your cortex becomes active in thinking, but the brainstem has not yet recovered from the sleep. In this condition, your body remains paralyzed because of the sleep, but you can hear everything that is going on surrounding you. And this strange feeling of not being able to move, but also hearing sounds, make us hallucinate. We start thinking that there are entities in the room or sitting on my body, which is preventing me from moving out of the bed. This causes intense terror and fright, and this is known as sleep paralysis. In general, sleep paralysis is a benign condition, and we don't have any reports of death occurring because of sleep paralysis. But if it compromises with the quality of life, then it has to be treated. In most cases, these sleep disorders do not have any specific treatment. We usually do a polysomnography or a multiple sleep latency test, find out the problem in the sleep, and therefore treat the sleep itself. That usually relieves the sleep disorders. So if we summarize some common parasomnias, sleep terrors are common in young people. They are part of the non-REM sleep disorder, and people do not remember that episode. Nightmares can occur at any age, common in patients with post-traumatic stress or anxiety disorder. It's a REM sleep disorder, and we can recall the dream. Sleepwalking is also common in the younger age. It's a non-REM sleep disorder. It can cause injury because the person is walking around. And sleep paralysis can occur in adolescents, but virtually in any age. It's a REM sleep disorder. It is often seen in patients with narcolepsy, where it is called hypnagogic hallucination. And it occurs as if the person cannot move and there are entities moving around in the room. So these are summary of some common parasomnias. So up to this, is this clear to everyone? So let us try and solve the questions that we started with. The sedative drug having a minimum effect on the sleep stages, muscle tone or seizures is? Yes, the answer would be the Z drugs. The answer is B, zolpidem. Next question. Insomnia secondary to depression is best treated with? So here we see that melatonin and diazepam are definitely not drugs of choice. Fluoxetine and doxepin are antidepressants, but fluoxetine is an SSRI, so it will further deteriorate the insomnia. Doxepin has additional antihistaminic effect, so the answer will be B, doxepin. Modafinil can be used to treat. Yes, the answer is B, narcolepsy. Modafinil is a stimulant drug, so it is used to reduce sleep in narcolepsy. AHI between 15 to 30 indicates? Wonderful, it represents moderate sleep apnea. All of the following are non-REM sleep disorders except? Yes, the answer is nightmares. Nightmares are REM sleep disorders. Sleep paralysis occurs during? Sleep paralysis is a REM sleep disorder, so it typically occurs in REM, at the transition between REM and waking up. And the last question, which one is the true statement? The answer will be C, because sleep terrors are usually forgotten, so option A is wrong. Nightmares are usually remembered, so option B is wrong. Rameltian is a melatonin agonist, so option D is wrong. So we are left with C, obstructive sleep apnea can lead to cardiac disease. So I hope this answers most of your confusions on EEG sleep and sleep disorders.